over to our next speaker.
Go, yeah.
So we've got Yala Downs in the room. So Yala is the Senior Scientific Officer from the Biological and Applied Environmental Hazards Unit. Yala's worked in metro, rural and remote WA as an EHO and has been with the Department of Health for 15 years, managing a range of portfolios including skin penetration, public buildings, events management and mould. We'll just click over to yeah. So just Yala will discuss the crucial role of local government authorised officers in the investigation of Legionnaires disease outbreaks.
Right, thanks, Bree, and thanks for having me. So unfortunately, due to the nature of our roles, I'm going to sort of overlap a little bit with what Richard talked about, but with a different focus, so bear with me. So we are talking about Legionnaires primarily caused by Legionella pneumophila, which is the water-based bacteria. We don't actually investigate the Long Beachy cases anymore, which is the cases caused by interaction with potting mix and soils, because they tend to be one-off cases. They aren't linked with outbreaks, so we just prefer to continue to put out educational material about handling soils safely. So just to give you a bit of an idea of the number of cases we get each year, the green is the Long Beachy and the purple is the pneumophila. So you can see that historically we've had way more Long Beachy cases in WA than pneumophila, with the exception of last year. For the first time, pneumophila cases overtook the number of Long Beachy cases. So just touch on last year, a bit of a summary. We received 44 notifications of pneumophila last year. Of these, we investigated 31. So we may not investigate cases if they were out of WA for the whole incubation period, or if they were in hospital for the whole time. If they were in hospital for the whole incubation period, then what will happen is CDC will contact the hospital's infection control unit and they'll investigate internally. We also don't get involved very much with regional cases, but I'll touch on that a bit more in the next slide. So interestingly, of last year's cases, of the 44 cases, 32 were men and 12 were women. So it's very true that men are more susceptible to Legionnaires than women are. And this year, we've had 7 pneumophila cases and 5 Long Beachy. We have actually investigated 8 cases, as we were notified by Victoria Health that we had, they had a case that had spent some time in WA during their incubation period. And again, 7 out of the 8 cases were men. So onto the notification process. So the diagnosing doctor or lab will notify CDC by the notification forms that we're familiar with. And then CDC will conduct an interview using the Enhanced Surveillance Form, the ESF, with either the patient if they're well enough or the next of kin if they are unwell or even potentially deceased. And then CDC will notify us. They'll forward the ESF to our generic email address. Now, this email address is for disease notifications only. Unfortunately, if you want to contact the water team, you'll have to do that separately. Once we've received the ESF, we'll initiate the investigation in conjunction with the relevant local government or local governments. So in regional cases, the notifying lab or doctor sends the notification form directly to the local public health unit where the patient lives, who will then forward the ESFs directly onto the local government. So we're not usually involved unless the patient's been transferred to a tertiary hospital in Perth due to the severity of their symptoms. So this is a case that we received, and this is sort of typical of the email that we would send out. So in this case, we sent it to the City of Canning and Albany. But you'll notice in this case, the patient got the hotel that they stayed at in Canning wrong. They were a little bit delirious in hospital, and which is a common symptom of Legionnaires' disease. So we had to clear that up, and in fact, it was the wrong name, the wrong suburb, and in a completely different jurisdiction. So we sorted that out a couple of days later with the patient, who, when recovered a little bit, was able to remember that information very well. So by the time we send you this email, about 2 weeks has passed since they've been infected. So the incubation period is 2 to 10 days, usually typically 5 to 6 days. And then the patient may take a few days before seeking medical attention. And then diagnosis can take up to a week. So we are already on the back foot when we receive these notifications and when we send them out to you. So I hate to stress, I know you guys are all really, really busy, but it's really important that these cases are followed up fairly quickly. Almost every local government is great and follows them up straight away, but there are 1 or 2 that we have to follow up for weeks and weeks. It's hard enough to pinpoint the source 2 weeks after infection rather than waiting 6 to 8 weeks. So I will point out that we are available to assist. We can come out with you on investigations, and we can even do some of the investigations ourselves on your behalf if you need it, but you need to communicate that with us and work with us. Sometimes we'll need you to facilitate contact with certain areas because you know your jurisdictions better than we do. So for each location the patient visited in their incubation period, we will look at not only their property or the location they visited, but we will look at a 500-metre radius around that property. So this is a completely random location that I've picked. It's in Inaloo. So we look initially at a 500-metre radius, and you can see at the bottom the white line indicates a 500-metre radius. So we'll look all the way around that. But in ideal conditions, Legionella bacteria can travel 2+ kilometres from the source. But in the case of a one-off infection, we'll start off with a 500-metre radius because I think everyone, including us, would melt down if we asked you to look at a 4-kilometre area, every potential source within a 4-kilometre area. So if we get a second case in a similar area, we might look further afield, but we start off with just the 500 metres. So this completely random location, we can see to the very right-hand side, the east, you can see Bunnings Inaloo. You can also see the Inaloo Shopping Centre. I'm aware that there is a car wash in that area as well. To the southeast, you can see the cinemas. So that, and there's a few commercial premises in that area as well. So if this location was linked to a case, which it is not, let me stress, then there would be a few places to look into for this case. You can also see in the top left-hand corner there is a park, and because WA's prevailing winds are from the west, we would look into that park and see whether there are any water features, fountains, etc. So, examples of sources. Now, Richard's gone through this a little bit, but I can elaborate on where we've found cases, or specific cases. So, Cooling towers was fairly well covered in the last talk. Car washes, which I mentioned briefly, especially those that recycle their water, but Legionella bacteria can be found in stormwater. So if they are linked to a case, then we would ask for any of those car washes near the site be checked. Fountains and spray water parks, perfect delivery system for Legionnaires. Misting systems, so Richard mentioned the misting systems that you can find in supermarkets, fruit and veg places, and sometimes pubs. We did have one case that was potentially linked to a supermarket last year. It's the first one that we've had linked to a misting system, but we found Legionella bacteria only low levels, but it was deemed to be the most likely source. So we did look into other supermarkets or 3 supermarkets, and we found Legionella in 2 out of 3 of the misting systems. Showers, especially rarely used ones, so emergency showers, the picture on the bottom left there is an emergency shower. Or we do find quite a number of cases happen when a family goes away, either work or on holiday, and returns, so their house has been sitting empty for 2 or 3 weeks, and the very first shower that someone has leads to Legionnaire's disease. And we've also found it in mining camps where the same person might use the same room, goes home for a period and then returns for their stint and has a shower and gets it from there. So evaporative air conditioners, or domestic ones, do have the potential to cause Legionnaire's disease, but we've never had a case linked to an evaporative system in WA. So they're very low risk, but if we do have one at the patient's home, we'll possibly look into it. Some interesting ones, we've had one case that was possibly linked to their nebulizer. So we weren't 100% sure. The patient used it every night, have never cleaned it for years, but apparently they panicked when they found out that it could be linked, so they cleaned it before we could swab it, but apparently it was quite dirty. And we did have one other case that might have been linked to his bong, so that was fun. So if we ask you to investigate sources and you do end up taking samples, we do prefer water samples if possible, because the water sampling process is NADA accredited and the swabbing process is not. But sometimes swabs are the only option, so they're still better than nothing. So if we find Legionella bacteria in the water system, we'll recommend some remediation. So we'll either flush the system with hot water for several minutes, so more than 60 degrees for usually around 3 minutes, or we'll recommend chlorination if the water source is a water tank or something that can be chlorinated. UV light treatment is possible, but Richard is hesitant to recommend that. I have seen where they did put a UV light treatment after the chlorination system, and UV light destroys chlorine. So by the time it reached the end point, there was no chlorine left in it, and it had Legionella bacteria in it. So once we've taken some remedial steps, we'll retest and make sure that the Legionella bacteria is gone. If not, we might do some other remedial works. If those haven't worked, then we'll probably refer you on to Richard, who's the expert in all of this, who will have better ideas than us as to how to remediate the system. So our investigation results so far this year, the 8 cases, including the one from Victoria, 2 possibly contracted their illness from their own shower after an absence. We say possibly because by the time we got into their home to sample, especially one had been in hospital for some time and lived by themselves, so there was no one to let the local government in to sample. There were only one had low levels of Legionella and one had high background count. So sometimes the high background count can mask the presence of Legionella bacteria. So the Victorian case, as well as being in WA during the incubation period, had also been in Bali, and it was deemed that Bali was the most likely source. And we have had cases where they've come back from Bali and particularly been in a pub where there's been a missing system. So while we've only had one case linked to, or possibly linked to, a missing system here, it is common from Bali. We couldn't confirm the source in 2 cases and 3 currently open investigations. So in one of the open cases, the patient spent time in Bali, but is also experiencing serious plumbing issues at home where his only source of water is a rainwater tank. So very interested to get those results. Richard touched on the Auditor General's report. He's gone through the recommendations, so I won't go through those there. But internally, we have been reviewing our processes as to how we communicate with CDC and local government and the systems we use, because it's only been since 2020 that we've actually had a recording system. Before that, it was all done with spreadsheets and email. Is the only way to track all this information. So now we have a database that we use called RedCap, which is great for recording individual cases and the investigation, but it's not good at stats. So, for example, I tried to look up the number of fatalities that we've had due to pneumophila, and I gave up. It was too hard. So we need a new system, or maybe somehow tweak the one that we've got to allow us to better look into stats and those sorts of things. So, but for the time being, that's helpful. We're also, we've met with CDC a couple of times about our internal processes, how to communicate with each other. And we're also trying to get the regional cases onto our system as well. So all the cases and investigation information is all in the one location, so, and hospitals as well, because we don't always find out the result of those investigations where it's an internal one within the hospital. So it would be good to have a complete understanding in WA where our cases are coming from. Also in the Auditor General's report, they looked at 37 community acquired cases, and in those, potential source was only identified in 10, meaning 7% had no source identified. So it doesn't look great, but the problem is, because I mentioned we're looking at it several weeks down the line, we suspect where it's possibly come from. So, for example, the 2 cases I mentioned before, one shower had low levels of bacteria, one had a high background count, but we can't for sure say that that's where they got it from. So in a number of those cases, probably at least half or 60%, we suspect where it's come from, but we cannot confirm that. So yes, the 70% with no source identified doesn't look great, but unfortunately, when we only have one case and no linked cases, and they've been to a number of places in WA, we're looking for a needle in a haystack, so it's not always easy to find. The Auditor General's report did note that there were several examples of incomplete case investigations with a lack of participation or response from the local government involved. So that also makes it very difficult. So I acknowledge that communication from our end hasn't always been fantastic, but there have been some cases where it has been left for too long and it hasn't been investigated as a result, unfortunately. So that leads us to the end. So my number's there, generic email address is there for all things Legionnaires questions. So do we have any questions?
Yeah, so if there's any questions online, please put them into the Q&A function now. But thank you, Yala. Appreciate that presentation. So you were talking about the misting systems. So has it been, they're commonly used, I've seen them in pubs and shopping centres and the like. So is there any educational information that's available for these types of venues, what kind of awareness raising might be done to kind of at the start of the summer or the likes to kind of educate people about.
Probably more of a Richard question because he does the systems and I just investigate the cases. But yeah, look, we have discussed that is something that needs to get out there, and we have discussed it with a number of supermarkets about how to at least flush the systems out regularly and clean the nozzles either in boiling water or bleach. They can go in boiling water. So we have discussed it with shopping centres that have discovered it or pubs that have discovered it, but generally across the board advice, I'm not aware that there is any just yet.
Okay. So in terms of WA, we seem to have been pretty lucky not to have any major outbreaks over here, whereas there has certainly been outbreaks over in the Victoria, South Australia and the likes. Do you have any theories as to why that might be the case?
We might have a drier environment here, so the bacteria doesn't travel as far, potentially.
Yeah, and I guess the eastern states as well, they've got quite, since those outbreaks, they have very robust legislation. And a lot of the bigger facilities like the shopping centres and the like, from my understanding, they're operating from WA to those quite hefty standards already because of the insurance implications and the like. So I think with, hopefully a lot of WA operators are already working to those standards because of that.
Yeah, we find most of them are. So, when we contact local governments, they'll regularly find that they're sticking to the East Coast legislation and sampling and maintaining their systems at least monthly. So, we at least the bigger centres are doing that, which is great.
Including the hospitals and the aged care facilities too. I think there's already a decent level of awareness that Legionnaires is a high risk for those types of vulnerable facilities. So
yes, this WA Health adopted the N-Health guidelines a number of years ago, I want to say around 2015-16, which covered hospital systems and healthcare premises. So they should already, all WA Health owned facilities should already be using those.
Yeah. And in terms of the potential centralised register in the new regulations, that will certainly help with future investigations as well. Great. So I know, for example, in South Australia, they, you've done your radius. It was a 50 metres? No, 500 metre radius of potential sites, and then being able to contact those venues within that radius and say, look, there's been a known case, and recommend some decontamination or checking of the system, so that way everybody's informed and action are being taken by facility owners to address the issue. So I think that would be incredibly helpful in terms of response, because it is difficult, like you said.
It's funny that they exist. We use the Google Earth function to look on roofs. To see if they have a cooling tower.
If there was an outbreak in, say, in the middle of the city, trying to figure out where someone walked past and what building might be responsible for those cases. It's so difficult trying to pinpoint it. So then just having those systems in place where you can target those within a certain radius to decontaminate their systems or check their systems would be fantastic for WA.
And we're also limited in what the patient can remember that they did, or if they're in the hospital, their next of kin trying to remember what they did. I mean, I can't remember what I did a week and a half ago. So trying to pinpoint every location that someone went within a 10-day period, not that easy. So people having trouble.
So we've got couple of come. I've just got a statement here. So I think when the department finds cases linked to workplaces, are there arrangements in place to notify WorkSafe?
Yes, we do do that. So workplaces can be a bit tricky because the patient hasn't necessarily told their employer that they're not well or what they've got. So first we have to get their permission to go onto their or to contact their workplace. And then, yes, if it is found to be linked to the workplace, then yes, we would notify WorkSafe. So there isn't an MOU or anything like that in place. That might be something that we can look at. Yeah, if we found it in a workplace, we would definitely notify our WorkSafe.
So in terms of the online resources, I think you were saying you've got an investigation response protocol online for EHOs?
I don't know that it's online, but what we do when we receive a case is we send them the SOP to follow, which details what type of things they'll be looking for, how to sample, filling out the PathWest form, which we also send to them because Legionella samples have a specific code that they need to use. So we send all of that out with the notification to local government, but that might be something that we can put online. It was done a number of years ago, so I might need a review.
And like you said, you've got staff yourself and others in the team that are on hand to guide local government through the process if you need support.
Me and Martika.
Yeah, and particularly in the metro area, you might have the capacity to help in terms of those investigations.
Yeah, regional ones not so much, but we're certainly only a phone call or email away in those situations.
All right, well, I think that's all that's come through. So thank you very much. Appreciate your time. We'll hand over to our next speaker.